lubricants, which is the bad liquids. And we are going to start with acute hydrocarbon ingestion by Ammar. Ammar, the floor is yours.
Okay, thank you, Dr. Suad. Okay, thank you, Dr. Suad. And my name is Ammar Al-Lamki, and third year resident in Oman Medical Specialty Board. So I'll speak about acute hydrocarbon ingestion. So maybe we are not aware of this topic, but there are so many substances around us containing hydrocarbons. So I will go through this outline. So this is my outline. First, I'll speak about the background of hydrocarbon toxicity, then clinical features, what is the role of chest X-ray in this type of toxicity, and what is the management of hydrocarbon toxicity. So hydrocarbons is a diverse group that contains an organic compounds which contain hydrogen and carbon. And as I said, there are so many hydrocarbon components around us. For example, as you can see here, the lighter fluid, it contains hydrocarbon. We have also the baby oil, which contains mineral oil, and it has a hydrocarbon in which is diluted in hydrocarbon. We have also furniture polish. So despite all types of hydrocarbons, they all share three physical properties. The first one, the viscosity. So as the substance has low viscosity, so it will be spreading very high in the tissue. And the second feature is the volatility. So what I mean by this, so this is the capability of the substance to change from a liquid to a gas or a vapor. So as the substance has high volatility, it will be highly toxic. Third feature is the surface tension, and this is surface tension same as viscosity. So as the substance has low surface tension, it will cause more diffusion among the tissue, and also it will cause more pulmonary toxicity if it is in the lungs. So I will go through a case scenario. So this is a 2-year-old child brought by his mother at 8 p.m. in the evening with a history of accidental ingestion of charcoal lighter. And they arrived to the ED 30 minutes post-ingestion. So the patient is in the triage. This is the vitals in the monitor. So the BB of the child is 95/60. His heart rate is around 100 and saturation is 93 in room air. His respiratory rate 44. And temperature is normal, 99.6. So from this point, so what do you want to do? What is next? As you can see from the vitals, is the only concerning is the respiratory rate. So what other components of the history that are important in hydrocarbon toxicity? So it's very important to ask about the timing and amount of the ingestion. It's very, very important. It can direct you from one way of the management to the other way. The third point is the exact name of the product. So usually the parents know what substance that the child has ingested, and usually they are bringing those substances. And you have to know the weight of the child to decide for the doses of the medication, and also the current medication and past medical history of the patient is very important. Now, what are the clinical features of hydrocarbon toxicity? There are three main organs that are affected by this hydrocarbons. They are mainly CNS and lungs and the heart. And the most serious side effects occurs in the lung because of the aspiration, as I will explain you in the next slides. So in terms of CNS, we have acute complication and we have chronic complication. From the acute, it causes transient CNS excitation, and that's why the abusers are taking this one. That's why they are abusing these products, because of the CNS excitation. But later it goes to CNS depression. Other symptoms, for example, coma and seizure, it occurs in around 1 to 3% in the population. We have also chronic complications, and this is seen in long-term users or abusers. So they got ataxia, they got spasticity and dysarthria and dementia. For the cardiac complications, the patient can get ventricular dysrhythmia in terms of VTAC and VF and atrial fibrillation as well. And he can go in cardiac arrest, and this is mainly because of the catecholamine surge due to the ingestion of hydrocarbon. In the GI, he has nausea and vomiting, and in severe cases, hematemesis. Other complications, for example, renal tube acidosis and contact dermatitis in case he get the hydrocarbons in the skin. So as I said in the beginning, the main organ of toxicity is the lungs. So the time ranging of the symptoms is the patient can come initially with cough and gagging, then it can be complicated by hypoxemia, bronchospasm, pneumonitis, and the worst situation is the ARDS. As you can see from this X-ray, so this patient ingested a kerosene. So you can see the infiltrate in the middle and lower lobe, how it's bad. Okay, now we'll go back to our case. So upon further history taking, the mother said the following. So their 2-year-old child grabbed a bottle of charcoal lighter off the counter and drank a little amount before 30 minutes. So his dad caught him quickly and took it away from him. So now how to proceed in terms of management, decontamination, and investigation in hydrocarbon toxicity. So the emergency and suppurative measurement is the key for any toxicity. So ABCD is the key of management. So you have to make sure that the airway is patent. So our child, he is talking, so the airway is patent. The second point is the breathing. So the vitals of the child is respiratory rate is 40, maintaining saturation 97 in non-breather mask, 10 liter, and chest auscultation is normal. And you have to put in mind, if the patient deteriorate, you have to arrange for early intubation if it is necessary. You have to assess the circulation of the patient. So our patient has heart rate of around 100 and his BP is 95/60. And you have to take an IV line for the patient. So in terms of investigation, so what to send for the patient? Usually for hydrocarbon toxicity, the lab investigation is time consuming and is difficult to obtain what type of hydrocarbon. So as an ER physician, you will not depend on, and you will not wait the labs. So you can send CBC, UE, LFT, and coagulation and VBG as needed to assess for electrolyte imbalance for the patient. But the single most important test to do actually is the chest X-ray. And it's required for all patients that presented with hydrocarbon toxicity, either they are symptomatic or asymptomatic. So what are the findings that we can see with this toxicity? So we can see a pre-hilar densities, bronchovascular marking, and bibacillar infiltrate, and pneumatic consolidation. Another point you have to put in mind that chest X-ray performed immediately on initial presentation, it doesn't have any predicting rule for the toxicity of the patient. So if the patient comes with hydrocarbon toxicity and you did a chest X-ray immediately after presentation, it doesn't give you what is the toxicity range of the patient. I'll explain to you later. So this timetable showed you the chest X-ray findings based on ingestion time. It's very important to know. So as you can see here, the time since ingestion. So after 1 hour, only 60% you can have findings in the patient. And as the time goes, the findings in the chest X-ray becomes more obvious. As you can see here, 8 hours. And in some sources, they are depending on 6 hours for the manifestations of the hydrocarbon toxicity in the lung. So by 6 hours, you need to repeat the 6 to 8 hours, you need to repeat the X-ray. Now, for the decontamination, it's very important what to do in case you have a patient with hydrocarbon toxicity. So the first thing you have to do is to discard the clothes of the patient because they are contaminated. The second thing, you have to wash the patient with water and soap. This is mainly. So discard the clothes and wash the patient with water and soap. And the third thing, if the patient has eye contamination, you need to irrigate it with water, only water. So decontamination is very important. The second thing, do you need to do a gastric lavage, or do you need to give the patient ipecac to induce vomiting? And what is the role of activated charcoal? So based on evidence, all of these 3 types of decontamination is not recommended at all, and you shouldn't do that. And what is the role of antibiotic and steroids? Is there any role? Based on evidence, steroids and antibiotic are not indicated in hydrocarbon toxicity, and there is no antidote for this types of substances. And also there is no role of dialysis. And so the mainstay of management is the supportive therapy, as we mentioned in the beginning. So back to the patient. So how you will approach him if he develop hypotension? So in a worst scenario, if the patient develop hypotension, how to approach those patients? So if he is initially on NIV, so reduce the beep because it reduces the backflow of the blood. And you should avoid beta agonist medication because it increases the risk of arrhythmia. And I mean by this, you need to avoid epinephrine. So in case the patient went in VF, for example, so just follow your ACLS, and you need to avoid the beta adrenergic agonist. So avoid epinephrine and use lidocaine instead of epinephrine. And this has been used successfully and proved by evidence. So now how you will dispose your patient? So based on this, based on the symptoms of the patient. So this is from the Oman Poison Control Center, a very nice protocol. So if the patient is symptomatic as our patient because of the tachypnea, we did chest X-ray in the beginning, so there was no findings. So now just follow the protocol. So chest X-ray, evidence of hydrocarbon aspiration on pneumonitis, it was no. So just observe the patient for around 6 hours. If he is if he is asymptomatic, discharge him on a follow-up after 24 hours. If he has symptoms, just admit the patient for observation. But if he had like hypotension and collapsed airway, he need intubation and should be admitted in the ICU. But the patient should be admitted if he deteriorates. Be aware of inhalant abuse. So because some patients, they are inhaling the hydrocarbons substances, as you can see from the first image, they are bagging the hydrocarbons in which they are pouring the hydrocarbon in a bag, then they are inhaling it. The second image, this patient, as you can see, the burns around her mouth, and this is because of the contact dermatitis because of the hydrocarbon substance. So actually, this patient, this happened in 2015, in which the patient was arrested in a hypermarket. She was inhaling a keyboard cleaner. So inhalant abuse is common in teenagers in several methods, for example, sniffing, huffing, and bagging. And the patient can present with ventricular dysarrhythmia, and they can went in a sudden sniffing death. This is because of the catecholamine surge. So what are the take-home messages? That pulmonary aspiration is the most common cause of mortality and morbidity, and do not underestimate the severity of the symptoms. So even if this patient seems in a minor ingestion and minor symptoms, you need to observe the patients. And there is no evidence to support the use of prophylactic antibiotic or the steroids. And the single most important test you need to do is the chest